We'll just get right on into it. I'm again Joe Conflitti, and I've been here 13 years now, and this is kind of one of my passions about taking care of folks with hip and knee issues. So what we're going to talk about is basically 4 separate topics, but they all are related, and that is, what is joint pain? What are some common causes? What are the treatment options? And we're not just going to talk about surgery. There are some very good non-operative treatment options. And then how a joint replacement does work. And there's many ways that they work, but we'll go through a few of them as the time goes on. And then our main focus is, how do we introduce new technology into that to improve how our patients are doing? Because that's our whole goal, is we want to make sure that you can perform and do function that you really want to do. So, as you know, joints are involved in everything you do, right? Getting here, getting out of the car, getting up this morning, everything you do really is how your hips and knees function. And that's true about really any other joint, right? As you're moving and using them, they're important. So as they become diseased, they can severely limit what you do. And it's not just about moving or walking, it's about even sleeping, right? At rest, if you're sleeping and things are hurting, you're going to have bad sleep, and then the next day is going to be significant as well. So it's sitting, it's standing, it's bending, stooping over. All those things that we do that are relatively usually easy can then be quite difficult. And it doesn't really affect you until it starts hurting, right? You kind of go about your life, and until your shoulder starts hurting, which mine did a month ago, you really don't think about it. But when it does, it's pretty significant. So joint degeneration can be really constant, or it can come and go. And there's really not much explanation for it, but it just does happen that way. It can also occur with movement, but it also can occur with rest, or a period of rest. So a lot of people describe being pretty good sitting down, but what happens? You get up and, oh, those knees are killing me, right? And then you get going and moving a little bit, and then it kind of eases itself out. So the other one is, it can be in many other locations, right? Today we're going to talk primarily about hip and knee, but it can be in your shoulder, it can be in your neck, in the hands, and there are other reasons for those, and we'll not really focus on those today, but they're important as well. So the common cause of joint pain is good old Arthur, right? Osteoarthritis, or regular arthritis. The reasons for osteoarthritis can be genetic, so it can be passed along from your family, or it can be what we think of as environmental. In other words, kind of wear and tear. As we all get older, the joints wear out. And interestingly, in humans, the cartilage does not repair itself. So if you cut yourself, of course, your skin repairs itself. Cartilage will not do that. The animal that does is pigs, and so there's research going on right now about how that happens, that they can damage their cartilage and then it become normal again. So osteoarthritis is that. It's the wearing out of your cartilage, and all the subsequent problems that you have and you feel are a result of that. So bone spurs and popping and cracking and swelling, all those things are related to that damage of the cartilage. We're not alone, right? 30 million Americans are affected by that in terms of their activity, probably more because some may not be as active as most of us. So that's one big group of arthritis called the degenerative. A second group is the autoimmune type of arthritis called rheumatoid, and there's some others in there as well. Not quite as common, so about 1.5 million people. And what that is your own body attacking the cells inside the joint. So what I tell people is, imagine your joint is inside of a balloon. The lining of that balloon secretes the fluid called the synovial fluid, the joint fluid that keeps it lubricated. When you have an autoimmune problem, those cells are actually attacking your own cartilage. And that's what rheumatoid is. And so eventually it turns into kind of the same process where your joint is degenerative. So it affects mostly those between 30 and 60. It's more common in women, but when men have it, it presents later. We're kind of not going to talk too much about that because it's not as common, but it still affects the patient the same way. You still have pain and swelling, dysfunction with your life, and the treatment is relatively the same when it comes time for surgery, at least. And one that's kind of left behind is this one, post-traumatic. Now, I train to do trauma surgery, so I do a lot of fixing of people that have fractures in terms of their hip joint and arms and legs. And so trauma to me is very important, but trauma can turn into arthritis down the road. So if you had a football injury when you were a teenager, or you were a weekend warrior in your mid-30s and hurt your knee or your hip, guess what? This may now be affecting you because When the ligaments are torn, or the meniscus is torn, or the tendon is torn, then your joint isn't stable. And the same process happens with cartilage damage. So we kind of have to figure out which group everyone is in and then manage that appropriately. So we can't forget about the cause of arthritis being trauma. So this is what it looks like, and it's pretty easy on this diagram to tell the difference. You can see here on the left, the femur, this is the healthy cartilage. Very, very smooth, it's white. And in between is the meniscus, which is kind of the cushion, and there's cartilage also on your tibia. You see the dramatic difference here where the cartilage is diseased, and this turns into essentially bone touching the bone. And you've had people, or you may have it yourself, where you were told I have bone-to-bone contact, and that's what that looks like. The secondary consequence is your body makes these bone spurs on the side. Those bone spurs then cause more pain because they're getting in the way of the ligaments, and so then you get not only popping and cracking, but your joint doesn't move as smooth. Here it is on the x-ray. I like to show this to everybody that comes in to visit because you don't have to be a rocket scientist to figure out which is bad, right? This is the normal, and you see here that there's good joint space, the surface is nice and smooth, but look at the difference. This is bone to bone. We do that with patients standing, so as you weight bear, I can tell that this surface gets much closer, and that gives us a better accurate representation of what's happening. And here you can even see on the x-ray, see that little bone spur right there. That too is then causing troubles. The same thing is for the hip. So the hip is a different joint though, right? The hip is a ball and socket, and so the knee is more of a gliding and sliding movement, but the hip is a ball and socket. And you see on the left, this is normal, same thing, cartilage on the ball of the femur. The socket on the inside has cartilage. As it gets diseased, the same thing happens. That starts to wear out. You get bone spurs on the side, the ball becomes less circular, and there we go with all those same symptoms. Here you can see on the x-ray, right, you don't have to be too smart to notice this isn't good, right? This is a ball that's not smooth, and you have this really hard bone, you have these cysts that form, there are bone spurs underneath, and you can even see that the ball is not even sitting under the socket, right? The ball is kind of sitting out to the edge, and so that's somebody that has really tough troubles in the groin and getting up and moving. So I like to show these. I think everybody hopefully can appreciate that when you have that pain and then you see it on the x-ray, you go, oh, okay, this is why I'm having troubles. So what are some common joint questions and joint pain issues? And most of them, in terms of the hip and knee, revolve around why is it hurting like in the hip? Why is it hurting in the groin? Why does it hurt on the buttock area? Why does it hurt down the leg? And for the knee, why is it not hurting in my knee? I know my knee is popping and cracking, but it may be hurting up higher or maybe even lower. We refer to that as referred pain or radiating pain. For some reason, the body thinks that the pain is elsewhere, but it's really not. And so that's one of the techniques we have to use when we see in the clinic to really focus in on what's the problem. Because if you come in and say, my hip's hurting, but it's really your knee, we're having a problem, right? If we're working on the hip and it's really not that. So those are some things we look at in the clinic to make sure we're treating the right thing. So the very, very first thing is, how do we treat this without surgery, right? Surgery has risks. There's a lot of issues with that. There's downtime. So we want to treat your joint as best we can without surgery. And the toughest thing to do is what? Is lose weight and diet. But that's the most important thing to regaining your function. And this is very true about how much weight causes a factor on your movement. And that is every extra pound on your body translates into 4 extra pounds on the joint. So I always tell folks 10-pound weight loss here is really a 40-pound weight loss here, right? That's a big deal. If your joint is arthritic like the one I showed before, if you can take 40 pounds off of that, imagine how good it would feel. Right? So diet and exercise we stress a lot of to try to manage that without any surgery. There are a lot of other things. One of them could be also using a cane or a walker. Now most people will say, no one's going to see me walking around here with a cane, right? You're not going to see me doing that. But it can be effective to try to decrease that pressure off the affected joint. Sometimes ice and also heat can be effective, but alternating. We usually recommend heat in the morning when the joint's real stiff, and then ice later in the day to kind of decrease that inflammation and the swelling. Other modalities, to include physical therapy, are very important. The physical therapists are really our best friends because they can help assist y'all and the people with arthritic conditions to get going with that exercise program. Many patients will come and say, well, I want to exercise, but I can't. My joint hurts, so I'm gaining weight. So what do I do? So the therapists then develop a really nice program to get that going. And so it revolves around low impact exercise, strengthening, stability, range of motion, and it's an individualized program. So everybody's a little bit different. They evaluate the first day or two, give you a month-long goal, and then shoot for that at the end of the month. And our goal after that is to then have that exercise continue so that you don't gain that weight back, right? And you keep that strength and stability going. The therapists are definitely our friends, but patients sometimes call them physical terrorists, but I don't know why. So then the next one, and I mentioned this last because it's really not as important as those others, but the last one in terms of non-surgical management are different medications. So they're medications over the counter like Motrin and Aleve and Tylenol to help with the inflammation called non-steroidals. There's a slew of prescription ones as well, but we have to be careful because they interact with other medicines you may be on. They have certainly some side effects. We also have joint injections, and they may be cortisone or lubrication injections. Those help to provide a better cushion, also kind of decrease the swelling on the inside. Again, some side effects, especially with cortisone, so we have to be kind of careful with those. So that kind of rounds out what we can offer outside of surgery. So what happens if you've done all that? And what happens if you've done all that and you still have pain, and you can't do what you want to do, and you can't sleep? Well, we're kind of at that stage, if that's the case. So if someone comes in and says, I've got a knee that's hurting and I'm ready for surgery, what do you think I'm going to say? Joint replacement? No, we've got to do the conservative management first. And once you fail that, but you still have pain, that's a significant amount of pain for your life, and you have dysfunction with your life, well, then it's time to consider a joint replacement. And I would ask everybody here, if you have that condition, do not be one to sit in the office and have someone else tell you it's time for a knee replacement or a hip replacement. That's your decision, right? You decide, once you've had this failed management of conservative treatment, then you decide when it's time for a joint. Don't have somebody look at the x-ray with you and say, oh, you got a bad knee, let's go to surgery. Because guess what? You're going to have some troubles, right? If you haven't prepared for that, you're going to have problems. So it's really important that you take the bull by the horns and make that decision when it's time. Now, we can assist you and say, okay, here's what the x-ray looks like, here's what we've done in terms of conservative management, and now maybe it's time to consider it, but I'd rather have you all tell me, okay, I'm ready, because then it's going to be much better in terms of the post-operative management. Does that make sense? Everybody good with that? Okay, so let's jump into a couple different things. One of them, we'll start with hip replacement. So hip replacement's done a lot, 300,000 every year. Knee replacement is more than double that, though. But hip replacement is very common. It involves essentially removing the arthritic joint. So we cut away this part of the bone, and we put in a new socket, a new ball, and a piece of metal goes into the femur. And that then forms the new ball and socket joint. Diagrammatically, I'll show it this way, and that is, whatever way you're doing the surgery, maybe from the front or the side or the back, this portion of the bone gets cut away. So you see here there's a sharp saw cut right there. The ball that was bad is removed, and then we have the ability to see inside and prepare this bone so that it will fit this socket, and it's designed specifically for your anatomy. We have different sizes, and then the particular ball goes on. Between is plastic, and then there's this metal stem that goes on the inside. And then once all that comes together, then you have a smooth joint. One thing you have to remember is once this is done, there's no more arthritis. That's gone, right? We take away all the arthritic areas. We take away all the bone spurs. So some people will come back and say, I think the arthritis came back to my hip. But it's not. You can have pain for other reasons, but it will never come back in that joint that's been replaced. So I think we have a little video here. Let's see if Lance can help there. Diagrammatically, here it kind of shows it. And it's kind of stripping away all the muscles. Obviously, we don't do that, but it's kind of showing you here's the bad joint. We make that cut to go away, and then from the inside, the socket goes in. The liner goes in, the plastic liner, which is the actual surface, and then the metal implant into the femur. We pick a particular type of ball, and then that goes back together again. The way that holds in there is we have to make sure that those components are in there accurately for your range of motion, but we also rely on all the muscles around there to keep that in place so that it doesn't dislocate, because you probably had people you know that had hip dislocation, which is terrible, so we want to try to avoid that at all costs. Okay, so switching gears, we have now the knee replacement. And so knee replacement is just not a total knee replacement. You can have a partial knee replacement. Before I go any further, I want to kind of clarify. I'd rather like us to talk about knee replacement in terms of knee resurfacing, because I think a lot of people get this idea that we cut the leg up high and down low and all this comes out and you have this bionic thing in the middle, right? It's not that. All we're doing is cutting out the very end of the bone, and I'll show you a picture of that in a minute. But depending on where the arthritis is, if it's just on one side, or if it's on the front and by the kneecap, or it's on all sides, then we can make a decision with you all on what's best in terms of the type of implant that goes in. And we'll spend a little more time on that as we go. So here's the difference. So this is a partial knee replacement. Let's say you come in with just pain on the inside of the knee. We've done all the conservative management, and we recognize that only the trouble is here on the inside part of the knee. And this is all healthy. Well, why would I cut out all this when this is good? So we just take out this portion and put in a new implant there, considered a partial knee replacement. Then as we progress down the line of disease and problems and issues, then we can do the full knee replacement. In other words, taking away all the diseased bone and then making this a complete replacement on both sides. Okay, so here's our diagram of the partial. And so you see that it's just confined to this inside edge right here. There's the diseased cartilage, as you can see, but everything else is okay. So what we're going to do is remove that portion, leave the rest of it alone, and then you have a much quicker recovery if we're going to do the whole thing. So there's the new implant on there, and now the diseased cartilage is gone. This is the metal on the femur, metal on the tibia, and then plastic in the middle. And now all the surfaces are smooth, there's no more bone spurs, and our goal is to maintain the other portion of the knee as long as possible. Having a partial knee replacement, though, usually means eventually you're going to have to go to a total knee replacement. But just as long as patients know that, this is a good bridge procedure, essentially, to maintain the rest of your knee healthy. Okay, so here's what it looks like diagrammatically. We have big words to show where it is, but essentially you can do it on the inside or the outside of the knee. Of course, this looks all healthy. Here you can do it at the kneecap. Some people have had knee dislocations in the past as kids or as teenagers, and then the kneecap is arthritic. Or you can do in several areas here. So again, this is not quite a full knee replacement, and the reason we would do that is it's a quicker recovery and your knee still feels the same. However, in the end, you probably would end up with a total knee replacement as the disease continues. So here it is. It's over 700,000 knee replacements each year, so more than double of total hips. So that's why it's a very common thing. And of course, as baby boomers are coming up, there's going to be even more. So we got to figure out a good way to do this so that we return patients to functioning quicker. Here is the total knee. And you'll see that the surgery, the incision portion is going to be almost the same, but the diseased portion is everywhere. You see that? That was bad cartilage everywhere. So now the femur gets recapped, so does the tibia, and then in between is the plastic, and then we have now a smooth joint. So you can see that it's really more of a resurfacing than a replacement, in that we're just taking off the very edges of the bone to get rid of the bad cartilage. So what are some common questions? I mean, there's a million of them, but a couple of them that are kind of interesting to think about is, can you be allergic to that metal and to the implant? So the implant is made up of an alloy of metal called cobalt chromium, and it has some nickel in it. Does anyone have a nickel allergy on your skin? Yeah, so the science seems to suggest that nickel inside your body is different from a cutaneous type of allergy. And so we typically we counsel patients about this, but usually it's not a factor when you have a surface allergy when you implant something on the inside. Will it set off a metal detector? Any guesses? Absolutely, it's a lot. It's kind of a lot of metal, and so the airport sensitivity is pretty high these days. So if you do get it and you get beeped, then they just say, okay, let me see, and they wand you, and then you go forward. We don't do those cards anymore. I don't know if you have people that had those before. They're worthless, right? Because anybody can just present a card. So you just have to show your scar and move on. And then one of the last one is, is it heavy, right? Am I going to gain weight? Are you causing me to gain weight, doctor? Not really. It's a little bit less than a pound, so it's not really a factor in that regard. So the main thing I think we're here for today, I hope, is how do we make technology help us to help a patient with a bad joint? And this is the way. And the technology has been there for a while. I'll show you a slide later. It came in about 2006. But I went to a meeting not too long ago, and one of the presenters had something very interesting. He said, in what field in the United States or even worldwide has robotics been introduced and then they threw it aside? Can anybody name one? There's not, right? If you in the car industry, when everybody was making cars by hand and they introduced robots, did they say, this robot stuff, that's no good. They work 24/7, they never want to break, they don't get hurt, we're going to throw that out, right? No, right? Robotics now in the car industry has revolutionized it, right? Made the car cheaper, better. What about the computers? I mean, nobody really builds a computer, the robot does, right? Military, right? All robots there. And so the same thing goes with medicine. And so the technology is there now to give us the opportunity to help patients. And that's kind of the goal, is to make sure that we're using this sensibly in the right way to then advance healthcare. And so the system, as you can see, we're unable to bring it over here because it's pretty sensitive, but it's a box. It basically has an arm, and we attach different instruments on the end to do those things I was showing you, and we'll have a video soon, but it's basically to help me cut in just the right way to make that implant accurate. And so far it's shown that we can make an accurate plan with this. It can protect the soft tissues, and that we can make it so that it really helps the patient get an accurate joint down the road. Right now there's some studies going on comparing patients who've had a joint replacement with the robot and without. They're actually doing a double-blind study where if you've had one with the robot, you don't know, and you've had one with just regular, you don't know. And so then they're tracking those patients to see what kind of success they have. There's an interesting, scale, you'd say, that tracks patients on how they feel with their replacement, and it's called the Forgotten Joint Scale. Has anyone heard of that? Probably not. There's a forgotten hip scale and there's a forgotten knee scale. Has anyone had a total knee or total hip here? There's a period of time where it doesn't feel like your own, right? And in a total knee, it's more than a year, where it still feels like it's artificial. It doesn't hurt, but it just doesn't feel like your own. In a total hip, it's about 6 months. And so the thought is, with something like this, is that we can shorten that period of time so that it feels so good and so natural that you just kind of move right along. There's a period of time where you have to do therapy and so forth, but if we can shorten that forgotten hip or knee scale down to 6 weeks or 8 weeks, then you're kind of back to normal again, instead of still worrying about it, rehabbing it, and all that sort of thing. So I thought that was an interesting thing in terms of using the robot. So this is just a patient testimonial. Doesn't specifically talk about robotics, but talks about how that patient got to doing what they're doing.
I am the grandmother of one. I have a husband who's a firefighter who's very active. For 20 years, I was an operating room nurse where I was on my feet all day. I was also very physically active. Biking, running, hiking, I was involved in everything. The first time I experienced hip pain was after a race. I didn't think anything of it. I thought that it would go away, so I kept pushing myself at work and with my weekly exercise routine. But I found myself slowing down. My range of motion kept decreasing, and I couldn't do the things that I used to do. When I finally decided to speak to an orthopedic specialist, it was too late. The arthritis had worn down the cartilage in my hip, creating bone-on-bone contact. It got to the point where the only recommended treatment option by my surgeon was to have a total hip replacement. Hip pain is exhausting. It is debilitating. I couldn't sleep more than an hour at night. I had trouble walking any distance at all. I stopped exercising completely. It's debilitating and depressing. It affected every aspect of my life. The pain eventually became so bad, I was looking forward to surgery. Looking back, I can't believe I waited so long. I had surgery on December 22nd, and the staff had me up and moving later on that afternoon. I was on my way to the airport after having surgery to go home when I got a call from my family that my daughter was going into labor. Now that's perfect timing. The Mako total hip replacement was a great choice for me. I feel better than I have in a long time. I can get back to the activities that I love to do. I should never have put it off for so long. I do a lot of walking. Walking's great exercise for me. I also use the stationary bicycle where I'm trying to build my muscles up so I can go back out on my road bike again. I would tell anyone not to wait as long as I did. I was in severe pain by the time I went into the hospital. I'm so happy with my result, and I plan to accomplish even more next year.
That's a pretty common thing that I hear, especially after a total hip, is that patients will come in at 2 weeks, we check their wound, make sure everything's fine, and almost all of them will say, "Dadgummit, why did I wait so long to get this done?" Right? Because it's this constant pain. Hip replacement is easier to recover from, but knee replacement patients will say that not at usually 2 weeks, maybe at 6, but hopefully that can get shorter as well. So a little bit more about how this all works. So quick quiz. Anybody know what these images are? David, you're not supposed to answer. That's my PA back there. Anybody know? These are CT images. And we use the CT scan before we go to the surgery to help with this process. So the CT scan gives us a lot of detail and images about your bone and the individualness of each joint. So everybody's knee is different, everybody's hip is different, and that's kind of the reason the CT scan is necessary, to give an individualized plan. So on the left, that's a knee CT, and on the right is a hip CT. And so with the technology that's there now, we can use this before you come to the operating room and create a customized plan. So the images that I showed you before gets loaded into the robot, and the folks at Stryker then take that and put it into the robot to make a 3D image. And I'll show a few more pictures about that. But it takes this virtual model of your exact joint so that then I can put on, before surgery, the right implant in the right position so that we know it's going to be perfectly positioned for you. And that's really the biggest part of this technology, is the ability to do that. So here you go, diagrammatically, this is a CT scan. A CT scan just kind of cuts you in terms of the image from top to bottom, but with the computers that are now there, we can make this 3D model, and you see this is somebody's real knee. It's probably a Sawbones model, but it shows that somebody's joint here, and here we've overlaid what the implant's going to look like, right? In terms of all the positioning of that joint, we can make it just perfect for that patient prior to doing anything. Nobody's in the operating room, no incision, no nothing. Here's the partial knee, so you see someone's joint is good here, and here's how we've overlaid what we think is going to be the right size and the right position of that partial knee replacement. So a lot happens before you come to the operating room. Same thing with the hip, and so in space then this image of the CT then gets modeled into a 3D image of this, and that model is amazing. You can rotate it in any plane, and I can look down on top of it, to the side, back underneath, and I can make sure that whatever size we're using here is going to match your anatomy. The goal being, of course, that it will match your functionality, right? We don't want a hip dislocation, we don't want pain, we don't want undersized implants, all those things. So then in the operating room, we verify that as being correct by then starting the surgery. So we open up the joint, whether it be the knee or the hip, and then I actually mark your actual anatomy as we're going through the surgery so that the computer knows where we are in space, and then we overlay that information so that then we can come in and make the appropriate bone cuts. So the robotic arm that I'm actually using is cutting away the bone to make sure that this implant is in the right position. So that's kind of the nuts and bolts of the actual technology. It's allowing me to put it just exactly where I want it to, and very, very accurately. So then after the surgery, these are typical images we get. And you can see here, this is what hip x-ray looks like after a total hip, with the ball and the socket in place, the stem down there. This is a partial knee with just half the knee or a third of the knee being replaced, and then this is the typical total knee that everything has been removed. So we're using the Mako triathlon. I don't know if you've heard anything about it, but it's been used a long time. About 2 million have gone in so far. What's unique about it is it has a single radius of curvature. We won't go too much into it, but it makes sure that the ligaments are tight all the way through a range of motion. And in doing so, we get a lot more flexion or a lot more bend in somebody's knee, but also it takes the stress off your quad if we can make that very smooth. So there was 2 million have been implanted so far, but all the companies are working hard, especially on the inside, on the plastic right between there, to make that better and better as it lasts. So common questions about technology. How long has it been here? They started in 2006. It was its own company. Stryker bought it not too long ago. Actually in 2009, some of the reps came here to Tyler and wanted to sell us the robot. And I wasn't a fan because it wasn't quite ready. It was still quite early and they hadn't worked out the bugs. And the worst thing to do is jump on the bandwagon early and then you make it worse. And so we waited, we let them kind of work out all the bugs. Stryker bought them, improved a lot of the software and the hardware, and now there's been 83,000 that have been done around the world. We got ours in 2015, I think. I think it was summer of 2015. We've done over 100 so far, partial and total hip replacements with that. It's been very helpful. Does it perform surgery? As I said, no, I'm actually the one controlling it, but it keeps me in that plane three-dimensionally that we make the cuts just right for everybody's individual joint. The recovery process is the same in that we're going to get you up the same day of surgery, walking with the therapist, usually just an overnight stay in the hospital, and then more therapy, and then home. Usually a total of 6 weeks of physical therapy, whether it be at home or in the outpatient setting. Our goal is to make this so good and make it so pain-free, I can't say painless, but if we can make it as limited of pain we possibly can, perhaps even to go home the same day. Right? Who wants to spend the night in the hospital with bells and whistles and nurses coming in and out? If we can get you home the same day, we think that might even be better. So realistic activities, all low impact exercises. Walking, hiking as long as it's not extreme, biking, swimming, but nothing high impact. No running, no marathon training, no rock climbing. We want to keep that minimal because we don't want that plastic to wear out in the between. And then driving usually is about 4 to 6 weeks, depends on which side it is, but it's more of a liability concern with the insurance than anything else. So at this point, as Stryker says, it's your move. That's their little tagline. Before we go into questions, I have one other presentation to do. We did our total knee Mako surgery on Monday, and we took some pictures with the help of Scott Berkeley, who did a great job, and I just kind of want to show you because I think it's a little more helpful to diagrammatically see what it looks like. So here we are starting. We have the patient's knee right here. We're putting on this little boot so that we can hold the patient's leg in space stable so that we make the appropriate cuts. Here we're starting the incision. The incision is basically the same, maybe a little bit different, smaller. The goal, of course, is not to make it too big and not too small. We want to get it just right so that we can see what we need to see. This is with the knee open. A little hard to tell, but can you see that there's no cartilage there, right? That's very bad looking joint. It's just bone to bone right there. There's bone spurs on the side, underneath the kneecap. There were quite a few, and that's, of course, why we're doing that, right? We're not doing a sham surgery. So this is our whole team, and it is definitely a team effort. Here's our robot in the corner. We're not quite ready to use it. You can see it has all the plastic on it to keep it sterile. Here's our 2 scrub nurses that help us get instruments. Right now, David and I are first doing the kneecap, so we do that free-handed. I don't have to use a robot for that, but of course the patient's knee is open. Behind there you can't see there's the anesthesiologist. Here's the first step, and remember I was saying I have to map out your individual anatomy. And so this little pointer, I'm making all these spots on this bone, on the open exposed bone, and I'm marking that. And I want to make sure that I get it in the right spot, and that way the computer knows where that knee is in space, and then we marry that to the image that we had before. So here's how it looks. This is the tibia. It's out of focus, but now I'm showing you, here's this little probe. You see it's a triangular shaped probe, and you have probes on the knee now, and we're looking back towards us at this camera, and that shows us, that tells the computer where this knee is in space. Here's a different view, kind of looking around, and here's this camera. See, it looks like a infrared camera and some eyes, and it's looking at those trackers to see where we are in space. Again, we have a lot of folks. See, I have our 2 circulating nurses. This is our Mako representative that helps run the machine because I can't run it and do the surgery. And here's our computer screen that's showing the implants in space to make sure that it's in the right position. You see all the instruments, right? These are just the normal set of instruments we use to do the surgery. Here's the robot getting ready to come in. We're not quite ready, almost. So, whoops. Oh, there we go. Okay, so here's right before I'm ready to cut. So what we've done is we've made this implant exactly where I want to on the computer. We've rotated it around. We've made sure that everything is just fitting right. And if you look real close, you see here these numbers, 18, 17, 17, 18. That's showing that the tension all the way through the range of motion is equal, perfectly equal. No way to do that without this. When we do it without the computer, it's just a matter of feel. And not to say that experience doesn't matter. I've been doing it for 13 years, and certainly the more you do, the better are you at it. But if I can add in within a millimeter of difference, there's no way I can do that by hand. So that's what's so cool about it. So now we're bringing the robot in. So there's Amanda, she's our Mako rep. She's pushing the robot in. They push it down on the floor, make it nice and secure. And here's the arm. And again, here's the trigger, right? I'm in charge of it, but it's just keeping me in that parameter that we already set. So now we're using it. Here's the knee bent up. Here are the trackers looking at the computer, and here's the camera, and there's the saw blade. We're making the first couple of cuts onto the knee. And here's what it looks like. I'm actually looking more at the screen than down here. So the screen is over here. I'm looking to make sure the saw blade is cutting. What I want to do is get rid of the green. So that's the cut I want to make. I'm looking at the screen. We're looking at the patient, but it's really more looking here to make sure that we cut the appropriate area. Here's another one. We're making a different cut. Again, you see, I'm not really looking here that much. David's helping me, but we are looking, but we're making sure that we're going to make this cut just perfect. Here are all these trackers that are watching the camera. Now we've got the trial implants in, and now we're assessing how well it's working. Is it nice and smooth? Can I get it all the way straight? Can I get it all the way back? Is it stable? And we verify that before we put in the final implants. And we accepted it. It felt good. It felt great, actually. And so now we're taking out the trial implants. We're taking off all these extra trackers, and we're ready to put in the real thing. And here's the real thing. We let the tourniquet down, make sure there's no excess bleeding. You see the shiny implant. It was a little hard to tell, but that's the femoral implant right there. Here's the kneecap that's kind of turned over, but now it's all in and ready to patient be woken up. Here we're closing it, and then that finishes it off. And then one final picture. These are our circulating nurses. They weren't in on the other picture, so I had to take a picture of them too. So that just about does it. I appreciate y'all's being here and attention. Hopefully that was helpful. Do y'all have any questions? The question is, do you ever do or suggest doing both knees at the same time? And the answer is definitely yes, but it depends on risks. So depending on the patient's overall status, it may be safe or it may not be. But typically, if the arthritis is bad enough and the symptoms are bad enough, then we will do that. My partner and I, Dr. Divinity, do them actually at the same time so that you actually get 2 knees done in the same amount of time. But a very good question. You get the rehab done at one time and then it's quite good. The question is, the range of motion now after knee replacement is not that good. Right. Is that right? And so what if we can't get the range of motion perfect as we see here? Right. Well, we don't leave the operating room until it's perfect. Okay. So there are other things that we do to make sure that we have full extension and full flexion. But the second you wake up, you don't want to do either of those. And so that's the point of doing the rehab. Yes, sir. Oh, that's a great question. In fact, there's been 2 or 3 studies now in the last 3 years about obesity and the risks with surgery. So kind of a roundabout way to answer your question, but anybody over 40 on the BMI, so that's body mass index, considered morbidly obese, has a significant risk of having surgery with hip and knee replacement. It's about a 75% chance to get a wound complication, wound infection, wound dehiscence, in other words, wound opening up, if you're over 40 on the BMI. And then that relates then to diabetes, it relates to heart issues, other things. So what we do is we counsel patients that if it is time for a knee replacement or hip replacement and you failed conservative management, if your BMI is over 40, I can't in good conscience do the hip or knee replacement. It's essentially negligence, right? Because I know you're going to have a problem. So we have to really be, stress the importance of that weight loss, which is difficult. So. Right. So the question is, we mentioned walking and cycling, different things, but anything low impact, and what was mentioned was about the elliptical machine, which is excellent, because what you're doing is basically exercise without any impact at all. So the elliptical machine is great, the rower is good, the lean back cycling machine is good, so all those are really helpful for both hip and knee, right? They're excellent. Yeah, so the question was, does it over time wear down on each other? And yes, that's part of the thing we talk about with our patients, is that this is an artificial joint, right? And so it's not going to last forever. Depending on how well you do with it, it may last 15, 20, 25 years. Eventually what happens is the plastic in between wears down, right? It's metal on plastic, metal is harder, the plastic wears out. As it does that, then the implants that we put on the bone, they're not stable anymore. They start loosening and toggling. Patients come back then with pain, and then we have to consider doing what's called a revision, or doing it again, which is a lot bigger deal. Good question. Nothing was said about the ligaments in the knee. Well, the ligaments are all left in place, and part of the reason that this is so good in terms of the robotic portion of this is that it helps me balance them properly. So the common one is when people have bad arthritis, you're bow-legged, right? It's not from horseback riding, right? It's from your knees are wearing out on the inside. So when that happens, that inside ligament called the medial collateral ligament, it gets really tight, really tight. The outside ligament gets loose. And so if we were to just leave that as is and put the knee implant in, it would be terrible. You'd have terrible range of motion, you'd have pain. And so we balance those ligaments so that they're equal tension, so that you have a smooth range of motion. But all the ligaments are left on the side alone. The inside ligaments are actually taken out. The ACL and the PCL, you've heard about ACL injury, those all go away because they're actually non-functional. When your knee is so arthritic that you need a knee replacement, neither of those ligaments are working. So they go away. Great question. So the question was, which way do you do a hip replacement, and what are the pros and cons? So hip replacement can be done from the front, called the anterior, which is right here. You can do it from the side, or you can do it from the back. And it's all about how you get in. The actual surgery itself in terms of the implant is the same. It's the approach. And so a lot of studies have been done on that. The safest one in terms of risk of dislocation is doing it from the front. I've gone to doing it from the front now for the last 7-8 years, mainly because I don't have to cut any muscles, and the recovery time is much, much quicker. Patients get up and go. There's no restrictions. They can go up and down the stair. They can cross your legs. You can do whatever you feel comfortable. And the pain is a lot less because we're not cutting anything. However, if you look at the studies in patients after 1 year, there's no difference. So if you've had it from the back and someone who's done a good job doing it from the back, you've had someone who's done it from the side who does that all the time, or from the front. At 1 year, the outcome of those patients, the functionality, their pain, everything about them is no different. So, but a year is a long time. And so doing that from the front, I think, is really helpful. And I can do that, obviously, with robotic control. The question is, on a total knee, do you do anything with the kneecap? And that question is a little bit debatable. Some surgeons will leave it alone or just assess it in the operating room, whether it's significantly worn down or not, and others will just replace it all the time. The literature shows there's no difference in those two. However, if you don't have it resurfaced, you're more likely to have another surgery to get it resurfaced. And so in my practice, I resurface it every time. And the way it's done is basically the bottom half is cut off and a plastic button goes on, and then that rolls around on that groove of the metal. And so that knee pain is not there anymore. The question is, this gentleman's had a knee replacement and has a drop foot. The only way that would get repaired is if you had some nerve surgery to get that better. Sometimes nerves can be affected with knee replacement, particularly in those patients that have what we call knock-kneed. So if normally I was showing you most patients are like that, right? If you're knock-kneed like this, which can happen, and we replace that. What ends up happening is the outside ligament here, or excuse me, outside nerve, then is stretched. And when you stretch it that quick, in a matter of an hour of a surgery, then the nerve cannot function. So we have to be really careful with that condition. So that may have happened, I don't know. The only way to repair a drop foot is sometimes you can change tendons around, so the tendons that work, you put to the front of the foot, and then you can get that back. Oh, the question is, what do I think about stem cell injections? There's another one called platelet gel. Right now, it's not approved, and there's no convincing science that it works. There's anecdotal evidence, and it's expensive. And so they're working on it. My guess is that at some point it's going to be acceptable, but probably for not late stage disease like we've been seeing. So if you have it in very early stages, we may have to go in with a camera and look. If it's just very early arthritis, there may be some science to that. But when you see what we saw here today, with it all the way down to bone and bone spurs and deformity, I highly doubt that injecting stem cells is going to totally reverse that process and alleviate the pain. The question is the incision the only one on the front? The front incision is the workhorse incision on the knee replacement. What happens on the inside layer is different. So some people go right on the front, but then what we do is we cut part of the quadricep tendon and move the kneecap over and do all the work. Some people don't cut that, move all of the muscle and tendon over. There's not any convincing evidence that one way is better or not. There's downsides of doing one and there's downsides of doing the other. So right now what we're doing is called a medial parapatellar, so basically cutting a little bit of the tendon, moving the kneecap over, and then repairing that afterwards. That's a good question, because we have someone who's going to be up soon about a partial knee. The question was, if you have a partial knee, what happens after that when you do a total knee? Depending on how the partial knee is done, the outcome of turning that into a total knee is identical as if it was your native knee. Because you don't cut very much off, especially when I'm doing partial knee replacement with a robot. Very little bit of bone is cut off. And then when the disease catches up in the rest of the joint, then you go back in through the same incision, you take out those old implants and put it in a total knee. And so usually those patients do just as well as if it was your native knee. I think we'll probably wrap up. If y'all have any more questions, we can answer them in the back. And again, appreciate it. Thank you very much. Thank you.